So my project is actually to understand and analyse how SCCT, Sheffield Community Contact Traces, worked over the past 2.5 years and to determine its impact on the local communities in Sheffield. A report is currently being written, which will be used to contribute to the government inquiry into COVID-19 pandemic and should be published on the SCCT website. So the methodology that I used was that doctors associated with SCCT, either currently or in the past, were sent an invitation to be interviewed. Participants got in touch expressing their interest, and they were sent a participation information sheet and a consent form. Following the return of a signed consent form, semi-structured interviews were conducted via the Google Meet platform. The interviews lasted approximately an hour with questions based on the founding of SCCT, its development as a voluntary organization, the organizational structure, projects produced, and any key outcomes that were seen. All responses were collated and themes were identified using the Braun and Clark's thematic analysis framework. And as you can see, the framework, the picture, there's a picture of the framework on the right, and it has 6 stages that are used to analyze the qualitative research. And on the top right, you can see a picture of me and Paul. We're doing an interview. So that's just a snapshot of how the interviews were conducted with the doctors. So some of the main themes that I identified while my research was how SCCT came into existence. So it was all started by a friendship group of retired public healthcare professionals and GPs. And this is such a good example of how community organizations step up in response to perceived gaps in the government's response to spreading infections. And some of these included a lack of effective strategy to deal with COVID-19 during the early 2020, inefficiency of the 111 service and the policy of excluding primary healthcare services, commercialized PPE contracts, delay in lockdown, and most importantly, the fact that no local contact tracing was carried out early on to limit the spread of the virus. And so the founding team asked an initial research question: is it possible to recruit and train local volunteers to undertake effective and safe contact tracing at a time when no contact tracing was being conducted locally or nationally? And thus, this all started off a local contact tracing research project, and soon many other subgroups and other projects emerged, such as the COVID confidence webinars, vaccination confidence webinars, delivering information about vaccination to BAME communities. And SCCT was actually also involved, a collection of enthusiastic volunteers who also formed part of the team. And currently another project is taking place to look into volunteers' perspectives of how SCCT came into existence. And all of this will be combined together in the report that will be produced. So how it developed, it gained an official status under the wing of Healy Trust Charity, which is a volunteer organization based in Healy and Mersbrook. Multiple factors contributed to this decision. Healy Trust was already engaging in a lot of local work and providing support to communities. This really aligned with the mission and vision of SCCT. They already had strong connections with local groups and, more importantly, Sheffield City Council. The trust had already had an existing organizational structure in place, which could be utilized to build a stable foundation, provide administrative support for SCCT, and also to manage funding. Working formally as part of Healy Trust would also give SCCT some sort of extra credibility due to its excellent reputation within the community. And so the people might be more willing to engage with SCCT and support the local contact tracing project. Very, very importantly, Healy Trust had a very strong volunteer workforce, which provided a significant proportion of volunteers who contributed to the projects. In addition to benefiting from the connections Healy Trust had, the founding members also relied on their personal network across Healy, Darnall and Burngreave cities. So, for example, they linked with Darnall Wellbeing, which is a voluntary anchor organization, and the picture on the right shows all the massive community of volunteers that work in Darnall Wellbeing and support the local people. So the main source of credibility was the fact that professionals had built trustworthy reputations within their respective communities. They were appreciated, they were respected, and they were trusted on a local level, which is why people believed the information that they were delivering. And all of them shared the same vision of tackling widening health inequalities and empowering local communities by offering advice and support for them to take ownership of their own health and well-being. The SCCT faced a lot of success and skepticism at the same time. There's a remarkable media coverage because they published a lot of BMJ opinion pieces. BMJ was quite receptive about their opinions on contact tracing and quite keen on them challenging the government. There were publications on inpatient contact tracing. There's another ongoing publication on COVID conversations, which looks at the impact SCCT had on local communities. Interviews were conducted as well. SCCT, in addition to this, also was subjected to resistance by the government and the Public Health England because they questioned the credibility of the work they were performing, as the local contact tracing, even though it was useful, it was conducted and tested on a small scale. And implanting a local contact tracing project without proper approvals or formal authority in place was a bit concerning for them. And they felt there was a sort of interference that was observed because NHS was running their own test and trace and SCCT conducted their own local contact tracing programs. So the key outcomes that were achieved were understanding the fact that government's broad one-for-all commercialized strategies are isolating and they're inapplicable to all the local communities, as each of them is quite diverse. Concrete solutions can be established by using a bottom-up approach where you work at a more local level with the marginalized communities, you identify gaps and provide personalized support. Recruiting local individuals from the same community is really important to get past the language and the cultural barriers. So for example, with NHS test and trace, people were supposed to record their symptoms, book in a test, but if they have language and transport barriers, they may not be able to book in a test, or a test center might be too far away for them to reach, or they might find it hard to isolate because they cannot get work off. And it's really important that we listen to these personalized concerns and support them specifically for those. And that is what SCCT stands for. In summary, public health systems at local level should be definitely strengthened by empowering local directors of public health rather than working in isolation. SCCT's future has not yet been decided, but all we know is that it's a brilliant team of professionally motivated individuals with a great set of skills, far-reaching networks, and creative projects. Wow. I just want to end this by thanking Tom for facilitating this student-selected component for my second year of medicine, and Paul for acting as an active supervisor. Thank you.
And thank you, Sanjana. That's a really good sort of run through of this, how we've been spending our time. It's good. Thank you so much. So open to questions now. Anybody? I can't see everybody's hand up at the same time, but if you shout out on your, or put your hand up physically. Judy, you have to unmute yourself and then ask a question, please.
Hi Sanjana. How much of this did you find new to you? Did you feel that you learned much from the work that you did, coming from whatever environment that you came from as a medical student or whatever?
I think on a very personal level, I did not know much about the inequalities faced by the ethnic and the local communities and the personal challenges they had. So I think the fact that understanding that personalized support is quite important was very, very new for me. and also understanding how an organization can just be set up so quickly and so suddenly in times of distress was very new to me.
Thank you. Paul.
Sanjana, from having done the interviews with the docs, sorry, just say that to begin with, we thought Sanjana would interview doctors, volunteers, and examples of organisations who we had a relationship with, but that just seems too much. So what I want to ask you, Sanjana, is whether you think those questions will be applicable and we can just find somebody to do the questionnaires with groups of volunteers, with a group of volunteers and with the other organisations, whether you think that'll work or not.
I think because the volunteers did a different set of work, we might have to alter the questions specifically for those, but majority of the questions would work for them because they focus on the organizational structure, how it was set up. I think questions regarding the challenges volunteers faced, specifically conducting each of these projects, would have to be asked as well, because they were the main workforce on the ground doing the mechanical work and conducting and releasing the projects. So I think more focus on that is really important, and we should definitely conduct pilot interviews for those as well, to gain an understanding of what we really want to put in the report and have a very diverse selection of volunteers.
Okay, time for one more question if there's anybody wants to ask Sanjana.
Is Safar asking a question, Tom?
Sorry, say that again, Paul.
It looks like Safar has got a hand up.
Okay, must be, sorry, there's so many screens here. Yeah, carry on, please, with a question.
Hi, Sanjana. I was just wondering, you mentioned some limitations, but were there any other limitations you could think of just along the lines of, like research and participants and things like that?
Definitely, thank you for this. Limitations, I think first and foremost, because this was a reflection of how SCCT was organized 2.5 years ago, it might be possible that some of the doctors might have forgotten some of the things. It might be hard to recall and go through all those things that have because many of the things have not been documented. So I think there might be a certain recall bias associated with that. Some of them were not involved with SCCT anymore, so they didn't have the knowledge of what was going on at the moment. So I think that might be a limitation we should consider for as well.
Okay, thank you so much.